Hello, everyone. Welcome to the NLC webinar session. So we'll just go ahead and start. Thank you for joining the call. But before we start the session of the day, I'd just like to remind everyone to please make sure you're muted at all times. This is to prevent any background noise or disruption to the webinar, and use the reaction button at the bottom of your screen for any engagement. And please drop your questions, ideas that you also want to share during the course of the webinar in the chat box. And use the raise hand feature if you want to speak, so that the host would then enable your mute button. Thank you. So without much further ado, I'm Halima. I'm from the SCIDaR, so who are basically the country host for the NLC. And I would essentially start off with introducing the NLC for today, before we go into the main objectives of this of the day, where we discuss the cost of social norms, who's paying the price and how are they specifically paying the price. With this, we have other facilitators that would guide you through the rest of the session of the day. So first, now I'd like to just segue into a short video introducing what the Nigeria Learning Collaborative, otherwise known as NLC, is all about. Enjoy.
I'm doing it.
Hello, everyone. Welcome back. So just to give you a brief overview, like you mentioned in the video, the Nigerian Learning Collaborative is primarily set up to actually achieve 4 main objectives. We're sharing knowledge about social norms to strengthen program implementation and coordination. And we hope to achieve this with this webinar. So without much further ado, I'd like you all to please introduce yourselves. But take note, for your name, I challenge you to spell your name backwards to see what it actually spells at, and then tell me what sector you're from and what communities of practice do you belong to. As we're waiting for everyone, I'll start. So Halima backwards would be Amelia. I see an Aifas as well, and Ulmer. Anialan. Hamitaf, Yineh, Yakhluq, Puja. All right, welcome on this social norms webinar. So as we're introducing ourselves, I'd also like to introduce the speakers that we have for today. So in-house from Selena, we have Raihanah Ibrahim. She would be the moderator for this session. Raihanah is one of our experienced norms here in-house, and with her would be Dr. Hamza Abubakar, who is the ES of Kaduna State Primary Healthcare Development Agency. He's with vast experience in health programs, strengthening and implementation, as well as norm shifting, as well as Sanda from the Kano State Primary Healthcare Management Board, who is also the State Mobilization Officer of Kano State. So he also has to do with a lot of norm shifting interventions in his line of work. So I'll hand you all over to Raihanah now, and I wish you all a fruitful celebration.
To this webinar. Today, the objectives of our session is to share some knowledge on social norms as it relates to their impact on population and how those ultimately affect development outcomes. Specifically, we will introduce you to the concept of social norms and illustrate the effect of those norms on development outcomes. We will also showcase specific person perspective stories that put a human angle to the social norms and how harmful they can be. And finally, we will highlight some general principles for including norm shifting strategies in all our programs as implementers in the development sector. So what are social norms and why do they matter? They are basically the unwritten rules that guide how a group of people behave. And it's a key concept in social behavioral change because understanding the norms help us to design programs that would really respond to the needs and the social concerns of the users of our systems or our interventions. Specifically, they are rules or standards that are understood by members of a group, and they would ultimately guide or constrain the social behaviors without the force of the law. They regulate the behaviors that people exhibit or consider normal. And for it to be considered a norm, we would say that they are driven by the anticipation of a positive or a negative sanction. So people would either not do it because they're worried that they would be judged or there will be a social sanction that would be a consequence of that action. And typically when we look at norms, theoretically, there are two types of norms: descriptive norms and injunctive norms. Descriptive norms are basically those norms that are basically due to our perception of what we believe is acceptable within our reference group. The reference group in this case could be in a family or in a community or in a community or a particular ethnic group or religion. So it's typically what we believe other people do. So basically, what are they doing? What are other people doing that we believe to be the collective opinion on that particular behavior? And secondly, we have injunctive norm, which is really what we believe other people approve of or disapprove of, as it were. In this case, these are more like the real life that is not based on perception, but is what we see other people approving of or disapproving of when we exhibit that behavior. Going into it in more practical terms, we have different examples of social norms. One very common and very notorious one is female genital mutilation or female genital cutting. For this one, to be able to profile the norm, there is a general way to do that where we try to profile the norm by looking at what the belief is, what the perception is, and what the sanction is in relation to a reference group. So, for example, for the female genital mutilation example, parents believe that their daughters will be seen as promiscuous by community members if they are not circumcised. And we know that female genital cutting is very prevalent, still very prevalent in sub-Saharan Africa, especially in the western and southern parts of Nigeria. Women who are caught are typically regarded as good or decent. But then we also know in practice that they are subject to a lot of complications, including blood loss, and infections and other postpartum complications or peripartum complications, as it were, when it comes to delivery and birth around that time. We also know that things like home births are considered to be the norm in some parts of Nigeria, especially northern Nigeria. And women believe that they will be considered weak if they deliver in the hospital, or in some extreme cases, if they have any assistance at all. There are women who believe that their peers or other women will consider them weak if they were assisted at birth, even by a midwife or a traditional birth attendant. And so those women would always strive to deliver alone, to deliver at home, and will only go to the hospital when they're really, really pressed or they're in a very dire situation where their lives are already hanging by a thread. And we know that that validation to be accepted by other reference groups costs us a lot in terms of our reproductive and maternal child health programs. All of us as implementers can testify to that. A third example is decision-making in families. Husbands believe that they will be emasculated by other men if they involve their wives in decision-making in the home. And we see how men make all of the crucial decisions at a very dire cost to women who are half of the population. We see the effects of this decision-making or lack of agency for women in the uptake of services of women who are typically the caregivers or the users of the health system. And we have some situations that are bad, so bad that when a husband is not around, a child could die if there's no husband to take the decision on, the care that should be provided to that child. But I want to quickly mention here that norms don't always have to be bad. There's some social norms that could be positive and could help improve the program when you're able to incorporate them into your interventions. And ES will tell us more around incorporating them into the interventions further down the line on this webinar. But just to highlight that there's some examples, like COVID-19 vaccinations could be boosted by religious and traditional leaders because it's a norm to respect those constituted authorities. Another example is giving out charity that is considered a norm, and that kind of helps to improve, would I say, the environment, for example. So if you don't throw out things and you believe in recycling and you believe in giving out old toys or old clothes, that kind of ultimately has what it contributes to the environment, right? So it's not always the situation that a norm is harmful, but we know that there are so many harmful norms that continue to affect the effectiveness of development interventions. To paint an even more, would I say, in-depth picture using numbers, We know that social norms are vast and they cut across many different categories: health, education, economic empowerment, and other kinds of topics or themes that have to do with the human experience. But looking at general or typical examples like cutting or circumcision of young women and girls, early marriage of young girls that ultimately take them out of school, or situations where girls don't even go to school at all, or where having a large family without birth control or family planning is considered a sign of wealth and affluence. And so that ultimately leads to a number of harmful things that we see in development. We know that out of school rates are very, very high, and 2 out of every 3 children that are out of school are girls. We know that labor force participation rate of women has been on the decline in the last decade and continues to fall even more since the pandemic. We know that VVF occurrence is very high, and Nigeria contributes to approximately 8% of the global burden. And of course, immunization, we know that only 33% of under 1 children in Nigeria are fully vaccinated for their age. And ultimately, all of the investments that we're putting into all of these development programs continue to not yield the effect that we would like to see. And that ultimately costs us a lot in revenue and GDP, so much unrealized human capital, increased death rates, mortality, morbidity is very high, treatment costs are also very high. We have overwhelming physical trauma. Polio causes a lot of deformity. There's chronic disability associated with some illnesses that continue to persist when they're chronic. And of course, there is just that general complete dependence on others for basic human needs that ultimately impedes collective development as we would like to see. And if we looked at the immunization example a bit more, we can see the stark differences between the northern parts of Nigeria and the southern parts. On the map to the left, we see the states that have the poorest coverages are in the northern parts of Nigeria. The program from the supply side is typically the same thing. It's resources going there and the same strategies that are being employed. However, the demand side issues continue to be the biggest bottlenecks, and these demand side issues are as a result of the prevailing norms that we find in many parts of northern Nigeria. And we can see how that translates to the 0-dose burden, that is children that have not been vaccinated with the pentavalent vaccine. We can see how high that is in the north, especially the northwest. And ultimately, we see how that contributes to the global burden of deaths that are due to vaccine preventable diseases. Nigeria alone contributes to 17.8, and most of the states that contribute to that 17.8 are in the north. And just looking at this picture, we can see just how important social norms are, how understanding them is very crucial to moving the needle, whether it's in immunization or in nutrition or in family planning or maternal health, and ultimately how much of a toll that has on us as a country or as a region or a continent, as it were. So we want to do a quick icebreaker here, just to kind of paint even more that picture that I just described. So we're going to do a poll now on Zoom. And the question is, how much do you think vaccination rates or low vaccination rates has cost Nigeria? or how much do you think the financial toll of low vaccination rates in Nigeria is every year? There's a hint there. It's twice the population of Africa. So if you give each person in Africa $2, you would get to the number that we have to spend every year as a country and as development partners to recover or to try to mitigate the damage that low vaccination rates does to our economy. Are we getting more answers? Okay. We have responses from 15 people so far. So we'll just allow a few more minutes for people to give their answers. Okay, we have about half of the participants voting, 26 people so far. Are we ready to see the answer? Okay, so we'll give it 1 or 2 more minutes for more people to log their responses. Good, we had 31 responses so far. We can reveal the answer now. Yes, so the correct answer is $2.1 billion annually in total is spent. This was extrapolated from a Gavi analysis of how much it costs over a decade. Over the last decade, it's cost Nigeria $20 billion for treatment costs for children infected with vaccine preventable diseases, and quantifying the lost economic potential for children that are dying from vaccine preventable diseases in Nigeria alone. But then again, that's not the most important thing. There's other issues, right? We know that approximately 120,000 children die every year. We know that there are millions of deformed and infected children. And of course, so much potential that is lost in that, with hundreds of farmlands that don't get cultivated, or houses that are never built, or new innovations, or new designs that never get to come to life because of all of these children that we're losing, and the disabilities that come from that. And so now we have seen what it means at scale for a country, or for a region, or for Africa as a continent, to continue to have these norms being perpetuated and not shifted or adjusted. So we want to now paint the picture from a person perspective, to answer the question, who is really paying the price and how are they paying this price? So I will hand over now to Sanda from Kano State Primary Healthcare Board, to give us a real life story of a person who has been a victim somewhat, and is having to pay the price of social norms decades down the line since the incident. Ado, over to you, please.
Okay, thank you, Raihanah. Hello?
Yes, Ado, please go ahead.
Yeah, thank you. Please, can you share this? Okay. Thank you. Good afternoon all. You know, this is
Hi, Ado. Seems like we're having some connectivity issues from your end.
get infected by BBF, he become a BBF victim, whereby in the society or in the community, they isolate her. Even he lost her husband. Everybody from the community, they are now abandon her. This make her to become so lonely in the community. Then for the norms shifting, the community need to be oriented or educated on this issue, and then to accept the situation where possible, and then to give her all necessary assistance where she may require in order to perform the real life along in the community. But before this thing, the norms shifting in the community has to be, there's a lot of things supposed to be done in the community in order to mobilize or to orient the community members to be aware, and then to change their behavior toward not allowing their wife to go for hospital delivery in case of where there's where there's an issue or there's a problem. She may quickly get assistance from the healthcare workers. But when you always allow them to stay at home, definitely some issues may warrant beyond the knowledge of the traditional birth attendant, and it will cause problem to the woman. And then at the end, you see the woman were abandoned by the community or by the society. Thank you, Raihanah.
Thank you very much, SMO. As we've seen from the case study that Mr. Adu has presented to us, Hadiza, our particular case study person-specific story, had to go through several social norms in her journey for a child that, she delivered and yet, never got to see life, starting from a young age where she was basically had to go out of school, largely because she's female and there was just no need, or the perception was there's no need for continuity of her education, to then an early marriage at the age of 17, which in and itself, in the society she is in is acceptable. But then when you sort of compound it together with the next social norm where contraceptive views, family planning, child spacing, whatever intervention we want to call it, is generally frowned upon because, it's seen as only promiscuous wives or spouses might want to do that, or other misinformation about how it's harmful and dangerous to women who use these contraceptives, to then the next social norm where, this was a household where women were not expected to deliver at the facility, despite the fact that, she was encouraged to go for ANC during her pregnancy stage, but childbirth is considered a normal thing that women do. So there was no need for her to go to a facility for delivery. And then you go in next where, she was in labor for 5 days. I mean, not 24 hours, but 5 days. So despite the fact that she was giving birth at home, a lot of complications arose with the fact that, she was just having local herbs that she was being given and, unsanitized area generally where this treatment was happening, because it was just like a home, not a sanitized environment. Delaying that care and not going to the facility, from even when they could see that there were issues up until 5 days. And then the whole complication that arose with the fact that the nearest clinic could not even help her. And so they still had to find a way and move her to the general facility, just sort of kept aggravating and worsening the situation. And then lastly, we have where she's finished all this journey. She's finally at the hospital. She underwent 5 surgeries. She's recovered now, but she can't go back home. She's homeless and has to be based at the VVF center, mostly because, you know, it's not normal according to society to see a woman holding her bag of urine. I mean, this is a story of Hadiza, but to the side on the screen, you'll see there's so many other stories, so many other Hadizas, not only in regards to just VVF, but we also have internet partner, IPV, internet partner violence that's happening. We have so many other social norms where at the end of it, women that have faced this are shunned by society for one reason or the other, and they have no one to actually confide in, and then it ends up being strangers that basically help them. So it's not just one social norm, but little things that happen over time. Over to you, Raihanah.
And it's really a great story. And I think that understanding the human beings, in our explorations for this story, we talked to women in the VVF Center in Kano, and it quite painted that picture of people who have kind of gone through a barrage of social norms that are currently responsible for where they are in life. And that's really just one subset of women or one subset of the population. There's so many other norms that continue to prevail and ultimately impact people and impact the economy or countries, as it were. So we want to take a quick break or a quick icebreaker again to drive the conversation, and we want to hear from you as implementers of programs across board, whether it's reproductive health, maternal and child health, immunization, or what other sector. Nutrition is also one of those that's pretty common. Women empowerment or economic empowerment broadly is also one of those areas where we see those norms coming into play. So please tell us in the chat, are there any experiences that you have encountered in your practice? And more specifically, is there anyone that is willing to share? You can raise your hand if you would like to speak, or type in the chat if you have a specific experience that you also want to share or highlight. It will be useful for you to tell us what the norm is and the impacts that you've seen that norm translating to in your practice. Oh, hi, Beatrice. Beatrice has a comment, or Beatrice wants to share. We're just going to give you the mic now. Please go ahead, Beatrice. Beatrice, please unmute your mic. Yes.
I have succeeded. Good afternoon, everyone. It's good to be here. One of the social norms we see around nutrition, there are several of them. One of them has to do with the first milk that comes out of the mother after birth. That is the colostrum, which is the yellowish milk that first comes out after delivery. The practice is that this milk is considered as devil milk, and therefore it is squeezed out and thrown out. But what we know in nutrition is that this milk is very, very nutritious. It is yellowish because it contains a lot of vitamin A, which the child requires for immunity. That's what gives it that yellowish color. And we say it is the baby's first immunization. But yet our people are not aware of this, and they squeeze it out and they throw away. So a lot of awareness creation needs to be done or is ongoing around the issue of colostrum and breast milk. So that is one. Another one is that in many communities, many children are not given protein food that will make them grow, such as meat and eggs and fish, because it is our belief that when you start giving children these foods, they grow up to become thieves. They grow up stealing. But this is not true. It depends on how you bring up the children. And they need these kind of foods for their growth and development. So these are a few of the norms that we have that are affecting nutrition in our many of our communities. Thank you. Over.
Thank you very much, Beatrice. Nutrition is also one of those where there are quite a number of norms. I think someone else wants to share. Etubi Ibrahim, you have the mic. Please go ahead.
Good afternoon, Ma. Good afternoon, senior colleagues and colleagues. Dr. Etubi Ibrahim from University of Abuja Teaching Hospital. As a resident working in a rural practice center, one story that comes to mind for me was a woman who worked in her third trimester. She was running a fever, she was weak, and we carried out her MP and it was positive. We needed to treat her, to start her on email. But when she came in, she said she would have to call her husband. She didn't even have the money to carry out the rapid test. So we had to do it for her. I think about 200 naira. Many of them come in like that, and even 200 naira they couldn't afford. So she had to use our phone, and then she called the husband who was away, and told him she needed to be treated, and all. So, but he said he was away until he comes back. She wouldn't have access to money to be treated, and may have to go home and come back till he's back. But as it were, we were afraid that if she goes back, she might go using other things and we may miss out on her and all. So we had to just go ahead, put money together for her and get her the medication that she needed. So many a times we see this playing out where male dominance in decision making, it's a norm. The man is the head of the family, so he has the access to the funds, and everything. So if, in fact, he will have to accept that you go ahead to treat his wife. If not, you may not be able to, she will not get treated. So this is something we see quite often in the clinic there. Thank you. Over.
Thank you so much, Etubi. That's also very prevalent, and you find that not just in gynecology, but also in pediatrics. You see the effects of the nutrition norms or nutrition-related norms that Beatrice described, where you find a child that is failing to thrive or is severely malnourished. And you also find that the woman or the caregiver that is the one with the child is not able to take the decision on what should happen to that child. And many times you even find instances where the father refuses the treatment and the child has to be taken back home. And of course, we lose the child down the line. So those are really sordid examples of how norms ultimately shape health and development outcomes broadly. I note that there are some comments in the chat. Chimelu will read those out.
Sure, thanks, Ryan, and hello, everyone. I think we have some very exciting examples in the chat box, and basically bordering around gender dynamics and how women are sometimes expected to only earn an income to the extent that they need to cater for the home and no more, so that they don't have a lot of decision-making power, both in the home and in the community generally. We also have some information around how when in some large families, the father would only train the male children because they don't see the training of the female children as an effective or a good investment, because at the end of the day, she becomes somebody else's responsibility or property, for lack of better words. We're also seeing a lot of information here about how the husband basically controls decision-making in the home, just bordering on what we had heard earlier, and some information around workplace dynamics, where sometimes women in the office are not allowed or are not seen as equals, but sometimes relegated to some menial tasks like making tea and running errands and things like that. Another interesting one that we're seeing here is education on contraceptives is interestingly seen as an opportunity to make students promiscuous, and I think that's very interesting. And finally, the last comment we have here is around sometimes some women are prevented from seeking care from male doctors just because of their husband's preference. So those are some of the examples we have in the chat box. Back to you.
Yeah, thanks, Chimelu. And someone is also mentioning mother-in-laws and how that norm of having either the husband or his mother ultimately make the decision. And we find that sometimes because of the long history of that norm, we find that women also perpetuate some of these norms that are ultimately harmful to their gender as well. Please keep the comments coming and keep the conversations going in the chat. We would like to hear from you. Just to also announce here that we are generally collating the prevailing norms that we find in practice in Nigeria through the work that the collaborative is doing. And if you would like to share any of those examples or norms that you found, as well as any norms shifting strategies that you've applied, please keep them together. Please feel free to share and indicate to us in the chat as well if you'd like to contribute to that body of work. So taking it forward is now we know why norms are important. We know what norms are, and we can come up with so many hundreds of examples of norms that we have encountered. We also know that these are things that have to do with social behavioral change, and that we're not trying to wipe out the culture. We're not trying to eradicate norms. We're just trying to make sure that they are not harmful in the process of trying to uphold our cultural or religious or societal norms, that we continue to advance the collective and the benefit of the collective. And as such, now we will seg into the next part of this webinar, where we will be discussing norms shifting approaches and what implementers need to do. This is very important because we're all here, we will all encounter these norms, but we need to have a mindset that tries to understand where our target beneficiaries are coming from. A lot of development work is structured such that we take the intervention and take it to the communities without necessarily understanding the whys of why some of these things happen. And we're not fully coming from a place of empathy and a place of understanding to uncover the norms and to program around those norms and to play the long game of shifting the norms that continue to affect our interventions. And if we're all agreed that those norms are harmful and we need to still implement within the purview of those norms, we will need to understand how to program effectively to address that. And so I will hand over the mic to Dr. Hamza Abubakar, who is the Executive Secretary of the Kaduna State Primary Healthcare Development Agency, and one of the advisory board members for the Nigeria Learning Collaborative, to take us through some of those considerations for implementers as we navigate this norms prevalent world. Dr. Hamza, over to you, please.
Thank you very much, Raihanah. Can you all hear me?
Yes, please.
Brilliant. So it's been a very interesting discussion. I was really kind of, I don't know, inspired by our willingness actually to share some of the, experiences we've had as we implement, as we provide services in terms of what social norms we encountered and what experiences we've had from that. We are products of our environment, and social norms, like Raihanah opened for us, is basically like a customary rule of our behavior. What are like the common standards, be them perceived or actual, common standards in our environment that govern our beliefs and our behavior. It's very important that we understand this because, especially for us, at the service delivery level, at implementation level, there is always a need. I think it's not a need. I think it's a mandatory situation where for service delivery to be optimal, there needs to be a balance between supply and demand. Unfortunately, as we design programs, we forget some of these considerations because probably me being a doctor, for example, I feel I have gone to school, I have been trained on how to treat malaria. I feel so proficient in my ability to treat malaria. Not forgetting that I might be in an environment where they've had a very, very bad experience with injections, and it has probably colored their perception towards injection to the point of shifting the norm in that environment. And I go with my, full regalia of injection if we were using injectables still to treat malaria. So these considerations need to be put in place. Now, social norms can be perceived or actual. And it's very important that we know the difference as we design and implement programs. The perceived are basically beliefs that we think our peers have, or the behaviors that we expect from them. And it's a two-way thing. It's the same as what the community that I'm planning to serve or I'm hoping to serve believe about what I think, or think about what I believe and expect from me as a behavior. But the actual, they are not subjective. They entail what the beliefs truly are and what sort of behavior are prevalent. And these are very important. If we look at some examples, it's a belief, generally that a parent who gives birth to a child should take care of that child, keeping him close by, feeding him, providing the necessary amenity for him to be in a conducive and safe environment, educating him, and so on and so forth. Now that's a perception, because in Nigeria now, especially in the northern parts of the country, it's an actual norm to have almajiris. These almajiris, as opposed to what we perceive as they are believed to be in a situation whereby their parents send them to a boarding Islamia school elsewhere, away from their town, and that with the belief that they'll be trained to become good people based on Islamic teaching. Not only that, they'll also be trained, you know, to become productive and good human beings. But you see how Al-Majiri comes with a lot of baggage in terms of health and other social repercussions. For example, in nutrition, I had some of the experiences we shared, I think Beatrice, right, with nutrition. It's not just from, you know, some of the beliefs we have from home. It can be an indirect outcome from some of the beliefs and practices that we actually carry out. Now, you've mentioned a lot of examples of, you know, of experiences that you've had in the course of, you know, your practice. Now, home delivery is a social event in many of our communities. And part and parcel of that social event is what we call in Hausa, the Unguwar Zoma. Unguwar Zoma basically is the traditional birth attendants. Some of them have been in the community for so long that they are celebrated. Unfortunately, on our part, we feel they are experienced, but they are not completely and adequately trained, especially in quick identification of danger signs for a woman in labor, for example. So, although if there's no complication, we feel they are capable, we are not so confident when there are complications. So how do we find a balance between shifting the belief in the community in Unguwar Zoma, or the traditional birth attendant, and changing the practice to the level that, at least if not anything, we have quick referral when there are issues? That's one example. The girl-child marriage has been discussed. It's related in a way to also prolonged delivery, which, you know, in Ado's presentation, he mentioned an experience about Hadiza. It's all related to these social norms. But I would want to, unfortunately, you know, bring to our attention the vicious circle of cause and effect. These social norms produced a Hadiza. It's the same beliefs that are, you know, shaping how we react to Hadiza's situation. Her husband leaves her. Nobody wants to be with her because, for example, she's leaking urine and it's kind of smelly and so on.
Yes, you are.
Oh, sorry, I had a little break in transmission there. Who is sharing the slide, please?
We will put it right back up.
Thank you. Excellent. You know, I was talking about Hadiza and, you know, the vicious circle of cause and effect in which she finds herself. Completely innocent, created by, you know, our culture and practice, and shunned due to her condition, in which probably she had zero whatsoever power to decide. But that's only another example. I've mentioned Al-Majris before. But I would want to bring to our attention, because I see, maybe because of the example we gave or what we are facing, I can see a lot of us here are in health. What we are facing in terms of our women and children, these social norms may not be completely the doing of just men. Like this case of Hadiza, if you go and dig deep, you would realize there's a lot to do with what the mother-in-law, some of the decisions that the mother-in-law took. So there's a need, as we develop our interventions and programs, for us to dig a bit deeper, you know, to see who are actually pulling the strings in some of these what do you call it? Some of these norms, you know, that we experience when we practice. There is this issue, for example, in one of the programs I worked with, between how you manage an HIV/AIDS patient who is a man who has sex with them. We call them MSM. You can see even to call them homosexuals is very sensitive in this environment. So we call them men who have sex with men. Believe you me, sometimes some of the meetings we used to have with our patients, HIV/AIDS patients, would be at 10 or 11 p.m. at night. So nobody can even see and know and maybe even guess what we are talking about. That is a serious issue. Other, you know, social norms are to do with probably how we perceive premarital sex and premarital pregnancies, which leads to people who need care, you know, avoiding it and going into all sorts of practices, unfortunately, because of the fear of retaliation, the fear of judgment, the fear of stigmatization. Now, just some considerations, you know, of what we do. Number one, to quickly round up, please, let's know that people, well, we are all human. And as much as we are trained, as much as we feel trained, the people to whom we provide services are human. They have their beliefs and their perceptions. And whatever we do when we supply, we must ensure we have feedback from the design stage of the demand beneficiary, the person who will enjoy the service. We must, you know, I mentioned it's very important we dig deep to identify and profile the relevant norms, including the broad perceptions, and go into the deep causative agents, you know, of some of the effects that we see. Then when we design our programs, it's very important for us to have human-centered design concepts in our mind. If we maybe want to know more about human-centered design, maybe we can research it for those who don't know. But this is a very good concept that puts into consideration the belief of the person we are hoping to serve. It's a concept that puts us in the shoe of the person we hope to serve, so that, you know, they say, do not do unto others what thou would not do unto yourself, right? So that's the whole concept of human design. But it's very, very important to have routine monitoring and evaluation of not just our programs, our activities and objectives, but to have responsive feedback, to pause and reflect from time to time how we are doing, what people feel about it, and how we can change. So some of the considerations or the tools we can use in trying to, you know, shift some of our norms are, as much as possible, let's understand that this is not a matter for one individual. This is a communal thing, and beliefs are very important. So interventions need to be targeted as a collective approach rather than individual. We should contextualize community-wide social behavioral change approaches. For example, you know, I mentioned drinking culture in some you know, environments in the country. Even in a state, for example, an entity as small as Kaduna State, we have some parts of the state where drinking culture is higher than other parts, where the message in these other parts may not be important. Just like we have some parts of the state where Almajiranci or the Almajiri concept is more predominant, and messaging cannot be done statewide to cover that other part. Mass media is very important, group education with boys and men, and please, let's not forget the other drivers in the community who, you know, can influence what are our beliefs and how we behave. So these are some of the things we face as we design programs around primary health care, considering that we are a very a richly social environment where really social norms dictate almost every of our behavior. Thank you very much.
Thank you so much, ES, for stressing some of those considerations. And of course, we can't go into social norms programming in one webinar, but we have a lot of resources to help to shape or to guide how implementers navigate social norms, everything from uncovering or diagnosing the norms. Before starting every program, the advised practice is to check the target group and check what the social norms are, what are the reference groups, what are the sanctions and rewards, what are those people really concerned about as it relates to the social environments within which they find themselves. And of course, aligning with the communities and making sure that even while implementing, you continue to get feedback and try to understand how well those programs are going. So we will like to do a quick Q&A session. Are there any questions from people on the call? While we were having this conversation, were there any specific things that you wanted more information on? Or, based on the tips that ES gave, are there any similar experiences that you're having and some challenges that you're facing that you would like to get into? The floor is open. Please indicate by show of hands or type your comments in the chat, your questions rather. Platform. The Align platform is a website that has quite a number of resources from the Nigeria Social Norms Collaborative, but also resources from other collaboratives. We have the East Africa Collaborative, and we have a broader collaborative as well, with many different tools and documented resources that will help implementers to incorporate social norms into their programs. So if you check the chat, you can find the link to the social network exploration tools that allow you to profile the norms and also profile the beneficiaries before rolling out your intervention, or even while the intervention is going on, as you continue to find that social norms are impacting your outcomes. Please feel free to click the link and explore the website and that particular tool. So are there any questions or any further contributions that anyone would like to make? Anyone? You can show by raising your hand or typing the question in the chat. It's also fine if you would prefer that your question is answered offline. We will share emails and channels that you can reach out to us or to our collaborators from the University of California, San Diego, as well as the London School of Hygiene, who have experts in social norms that will be able to answer more of your questions as well, should you not be comfortable asking your question here. Okay, I like to think everyone completely understands today's webinar. and understands the concept of social norms and how to incorporate it into their programs. I hope that you click the link as well to learn more about the Align platform. While we're very much ahead of time, seeing as we don't have any questions so far, could you please click the link in the chat that has the feedback form? Hunter just posted. Let's see. Oh, we have a question from Ezioma. And the question is, how can one use the human-centered design approach intervention to solve these problems? Yes, would you like to answer that question? Dr. Hamza? Okay, I can respond to that question in the absence. Okay,
Sorry,
yes.
Raihanah, I didn't realize I was still muted.
Okay.
So the human-centered design is a concept in itself. Now, it has some specific tools that you use, but just to summarize the whole concept is it's what you do or the steps you take when you are designing any intervention to step out of your skin and identify from the perspective of the beneficiary of that intervention what they need. You look at the person socially, you look at the person maybe anatomically, but that's going a bit, granular. But you look at also the context from which the person comes, including, the gender, the religion, the whatever, the economic situation. And then based on understanding the person and the environment holistically, and looking at what in that person or his environment is actually contributing to the problem you are trying to solve. Then you design activities and interventions based on that information. If you look at basically how we do our planning and how we design our programs, I'm sorry to say this, but sometimes we import programs from different environments that may not fit, our own context. We look at programs from the textbook or from the research papers that have proven they are okay in a group, of people, not having done the same type of maybe a research or study in our own group of people or the people we are, wanting to serve. And then it's after we implement at the tail end of evaluation that we realize, come to think of it, how come we never thought of this person or this environment or that context? So the human-centered design basically is a concept that brings us down to earth to look at our interventions from the point of the demand rather than our own point of supply. This is just a quick summary. I don't know, Raihanah, if you can add a little more. Thank you.
Yes, thank you very much, ES. And I think we will also share resources after this webinar as reference documents for human-centered design. Just to add to what ES has said, human-centered design is basically the fancy word for putting the user of your intervention at the center, meaning that you're putting yourself in their shoes and trying to solve their real problem rather than what you think is their problem. And the solution as well needs to be aligned with what they want rather than what you want as an implementer. There's a common story that people apply of where human-centered design was not used, where a community didn't have water and they used to fetch water all the way in a different neighborhood that had a stream, and they had to trek far away to be able to get access to water. And this NGO comes and puts a well in that community, and that way it's easier for women to go and get water when they need it. But the community didn't really like it because the women were happy to walk all the way to that place because that was their only opportunity to actually interact with their friends and chat. And for them, that was a good thing rather than a constraint. But then the designer did that from their own perspective of what the issue was, rather than actually understanding what those women were solving at the particular time. So that's an example that's typically out there in the development space. But practically, to answer your question of how one can use human-centered design approach to solve these problems is using the steps of human-centered design. There's different would I say schools of thought on the steps, but basically there are three things, which is the first one of observing or exploring, in which case you do some user research, talk to the users, try to understand, profile them, not just understanding the problem, but understanding them. And this is where everything around the social network mapping tool will help you to try to understand, as another Nigerian woman, for example, what is she solving? What is her social standing? What does her social support look like? What's her day-to-day life? But then what are the norms that ultimately influence her behaviors? And try to observe generally. We use different methods to do that. Common ones are key informant interviews, but there are also vignettes and shadowing where you actually just go and immerse yourself in that person's, would I say, day-to-day life, and just try to figure out what it is that their challenges are, talk to them and understand what that community is about, you know, as a whole. And then after that observation phase, you should have enough data to start to ideate. Ideation is the second phase, where you are basically thinking through different ideas that will address that particular problem, making sure that the solution targets the problem at its root. But then you don't just take that idea and go and implement it. Part of human-centered design is that it's continuous, it's iterative. You have to go back again to that community and test that idea with the users of the intervention, tell them, you know, how do you think this works? Get their insights and their opinion, or responsive feedback, as we also call it, is to get feedback from them and respond to that and use it to refine the idea that you've put forward. I'll give you an example. We implemented a 1-year routine immunization body system in Kaduna, which was basically putting women in support groups and also providing them loans that would serve as incentives, but also ultimately help provide the necessary financial resources for them to take their children to get vaccinated. And we use human-centered design approach, which changed a lot of what we wanted to do. We initially wanted to give them grants, because it was like a grant that we got as well to implement that. But then after interacting with the women, we understood that loans would be better because they also wanted it to continue beyond the 1 year period of the project. Another example is getting the husband's consent for the women to be part of those support groups. So it was with interacting with the women that we understood that the husbands needed consent. I mean, we knew that, but then we understood that the traditional leader was the best person to have that conversation with the men. And that was able to get us to get the husbands buying. We also saw the differences between the northern part of Kaduna and the southern part of Kaduna through our explorations. And we were able to tailor the kind of businesses that we upskilled them to embark on using those different context-specific information that we uncovered during our user research or observation phase. So those are kind of like the general principles of human-centered design. It's iterative, it puts the user in front or in center, and it follows a process of observation, ideation, testing, and then implementing. But also throughout the process of implementing, you're continually learning and getting feedback from the users and using it to refine your idea.
Beatrice's hand is raised.
Yeah, Beatrice, would you like to speak? Looks like it's an old hand.
Do we have other questions or comments?
I'm talking, yes. Can you hear me? Can you hear me?
We can hear you now.
Okay. No, I was going, before you started speaking, I was going to call our attention to the comment on the chat box by Taiwo. I think it's Modukwe Taiwo, that we need to work with the people and to find out, you know, they're just like what you have explained in so much details. I don't need to talk again. So you work with the people to understand their point of view of the issue at hand, and together come up with a solution to the problem. And that is what the responsive feedback is all about. And you've dealt with it very comprehensively. I have nothing else to add. Thank you. Over.
Thank you, Beatrice. We have a question in the chat that says, what intervention strategies can be used to shift norms associated with low immunization uptake? Anyone amongst our speakers want to respond to that?
Of course.
Please go ahead, Dr. Hamza.
So, wow, this one can actually take a whole webinar in itself. But let's look at it from the most, I think, traditional angle of what we are going through right now. Nigeria was certified polio-free 2 years ago. So let's, if we use, I know polio is, you know, a campaign-based kind of intervention in Nigeria, but let's take it quickly as a case study. When we started, everything was going well with polio vaccination until the negative campaign, I don't know from where, started to come. And actually, I'm happy to use polio because most of the negative campaign against polio had to do with our social norms. That in the polio vaccine, there were, what do we say, contraceptives, right? That in adulthood may hinder our ability to procreate, which has led to a lot of rejection that time. Now, what were some of the interventions that were used then? Number one, of course, we had to counter with a lot of media action, TV, radio, even before this one happened, even before social media came into being, actually. But of course, social media came and we also rode on that bandwagon. But it didn't, I think it wasn't the primary turning point for me. The primary turning point in our intervention in the country for polio was when we brought in the traditional rulers into our polio interventions and put them in the forefront, because in our environments, we still have a lot of respect and we still see our traditional rulers as key, how do I say, drivers of our social environment and our social norms. And we had to do a lot of advocacy. So this is one. Apart from the, mass media communication, we did a lot of high-level advocacy. A lot of buy-in was got from the Sultan, for example, in the north, or the Muslim side of being the supreme leader, the Islamic supreme leader, to all the way down to the villages, the village heads, and so on. We got that feedback. I don't know whether some of us know a situation at one point where one of the emirs actually opened up a bottle of the whole, one whole bottle of the whole polio vaccine, and actually drank all of it in front of the people, just to prove, to people that it was harmless. So the community-based interventions, community engagement, awareness raising, and so on, was very, very important. But then what informed the decision for us to use the traditional rulers? Simply due to the fact that the whole negativity we had around it was based on social norms. And we saw it, it's a form of, if you ask me, a human-centered kind of thing, whereby you looked at what the problem was, what the perception was, and went into the point where the best person, the best protector of that perception is the one now talking for you. So many of these things had to be done, and now we are certified polio-free. For routine immunization, there are other components of access, components of cost, and components of just simple capacity in terms of the quantity and the quality of healthcare workers providing routine immunization services. So honestly, many things we can do there, but always let's strike a balance as much as possible between demand and supply. Maybe, I don't know if we have anyone say a few more things. This one is a whole topic in itself. Thank you.
Thanks so much, ES. We have a hand up from Sa. I don't know if she would like to contribute to that particular question. Sa, please go ahead. Please unmute your mic and go ahead to speak. Looks like she's having some connectivity issues. Thank you so much, ES. I think that, yes, like you said, shifting norms in immunization is a mammoth. It's pretty big. But yes, demand generation, community engagement is key way to
Do you have any questions or comments on the session, or raise your hand or put in the chat box?
Thank you very much. Looks like Sa'a had some mix up there. But thanks everyone. We will share resources as was suggested. But yes, for immunization, a lot of focus is on demand and going into the communities to try to shift these norms. In addition to the traditional leaders, there's new thinking around engaging mother-in-laws. Who have been seen to also be very, very influential in family decision making. But ultimately, the approach is engaging men, engaging key influencers, and having the messengers not be the health system people, but the community people, and as well as role modeling. For COVID, for example, we saw instances where traditional leaders and political leaders as well took the vaccines, and those images were circulated just as an attempt to try to get people to understand that it's okay to do this and that it has benefits. So by and large, educating the communities at scale, but also going using tailored approaches and tailored messages is the way to do that, just to kind of summarize. So I think we are.
Sorry, Raihanah, just quickly in addition.
Yes, please go ahead.
Being such a communal environment, we live together, we do things together. The body program you mentioned that we did in Kaduna was excellent, you know, whereby you put mothers together of children of around the same, you know, age group, the same age requirement for immunization, and have them present their children to the facility together, have them do activities together, have them, you know, get a leader amongst them who coordinated activity. It showed a lot of improvement in the coverage for these children. This and other, you know, interventions and innovations are now upcoming that are helping us to improve with routine immunization. Thank you.
Thank you very much, ES, for highlighting that as well. And thanks everyone. We have now come to the end of the content part of this webinar. Please remember to fill the feedback form in the chat. And join the conversation online. Like I mentioned earlier, the Align platform, that is www.alignplatform.org /learning collaborative, has a lot of resources that you can use as a programmer. You can also see other insights from other collaboratives across the world. Please join the conversations on Twitter at NLC_social norms, as well as on LinkedIn via the Nigeria Learning Collaborative for Social Norms. You can also email us at info@nigerialearningcollaborative.com, where you can participate in all of the different knowledge products development activities, or participate in the next webinar. You would also find that you will receive our newsletter and also the links to our podcast once we launch it in the coming month. Thank you so much, everyone, for such engaging conversations today. Over and out from all of us at Solina and the Nigeria Learning Collaborative. Thank you, and see you at the next webinar next quarter.